The one on Facebook is the right one though.
Hello to everyone. My name is Angeliki Kolida and I'm a catheter radiographer at General Hospital Sklevio of Vouli in Greece.
Hello everyone, I'm here to talk to you about a project that we did.
Hello everyone and happy World Radiography Day. My name is Steve Lacey. I am the Director of Education with Isrrt. I also work at the Royal Children's Hospital in Melbourne, Australia as a radiographer as well. I'd like to welcome you all to this wonderful event where we celebrate patient safety as part of World Radiography Day. I'd like to introduce the President of Isrrt, Dr. Napapong Pongnapang.
Hi, good morning, America. Good afternoon, Europe, Africa, and good evening, Asia and Australasia. Welcome to our special program on a very, very special day, World Radiography Day. The World Radiography Day we established to celebrate the discovery of X-ray by Professor Röntgen back in 1895, that years ago. And during the time passed by, the technology progressed a lot, and radiographers and also radiation therapists, we are key person who deliver the service and care to the patient. So this year theme of the World Radiography Day is celebrating patient safety. This signifying the important role of us radiographers and radiation therapists for the quality of work and service that we deliver to the patient. And it is our commitment as a profession to advance the practice and be a bridge between the technology and the patient. And this is very important. That's why we have a special program today to celebrate the patient safety. And I also would like to thank to all the speakers today from across the world who come here to share your expertise and experience on this patient safety aspect of our profession. Thank you. And again, happy World Radiography Day.
Thank you, Dr. Napapong. We're really looking forward to this webinar, this event, where we celebrate patient safety on World Radiography Day. And we're going to kick off with our first speaker. Our first speaker is a colleague of mine, in fact, Amanda Potter. So Amanda is the General Radiography Supervisor at the Royal Children's Hospital in medical imaging. Amanda has quite a lot of experience, both within Australia and internationally as well. And her presentation is going to be regarding how we have communicated patient safety with our patients. Thank you, Amanda.
Hello everyone, I'm here to talk to you about a project that we did at our hospital to improve our ability to communicate the risk of paediatric radiography. This was a project was done in conjunction with our physics team, our radiation safety officer, Amanda Perdomo, and her registrar at the time, Victoria Earle. And what we were aiming to do was to estimate the radiation doses and the associated risk of the most commonly performed X-ray exams at the Royal Children's Hospital here in Melbourne. We wanted to end up with the clear and accurate information to assist us in communicating those risks. And this was in rise to the many questions that we constantly field from parents and carers, from staff within the medical imaging department and within the hospital, from other imaging centres, from other physicists, regulators, etc. Prior to this project, most of the data that was out there was relevant to adults, and the paediatric data was limited and outdated. You'll see here on the screen a chart that most radiography departments in Australia have or had, issued by ARPANSA, which is the Australian Radiation Protection and Nuclear Safety Agency, with a lovely clear format for equating typical adult doses to other risks, but it wasn't at all relevant to paediatrics. So we thought, let's make our own that is relevant to us. When it comes to communicating risk, it's a vast and fascinating field. There were 3 factors about risk communication that we considered were very, very relevant to our project. That is, how anyone views risk to a large extent depends on their circumstances and their comfort zone. And that's going to be things like previous experiences, education, field of work, age, etc. Explaining risk to anyone needs to be a two-way process in which both the expert and the lay person's perspective are considered. In other words, the lay person needs to be able to comprehend the risk and be able to then use it to make their decisions regarding that risk. And descriptive terms like likely or rare have shown to convey very elastic concepts and should be avoided because one person's understanding of a term like likely might be a chance of 1 in 10 where there actually is meaning a chance of 1 in 2. So being mindful of all of these things, we began to consider what we wanted to include in our project. Obviously, we began with the typical effective dose, but that alone cannot be used to communicate the radiation risk because it's dependent on many factors, including the age and the sex of the patient. So the effective dose would be used to estimate stochastic risk, and we'd categorize this stochastic risk with some commonly used risk terminologies. The stochastic risk would be expressed in the Kalman risk category. In 1997, a gentleman called Kalman suggested a scale with standardized terms for specified frequencies, which is used a lot to express risk in public health. We also equate the equivalent background radiation time, which for us in Australia is 1.5 millisieverts per annum. But as not all members of the public are comfortable or comprehend background radiation and would prefer Bert stays as a character in Sesame Street, we'd also include the equivalent stochastic risk of international flying times. Having decided what we wanted to include in our project, we began with the list of commonly performed examinations about which we received the most questions. and that is the list here in front of you. So the effective dose calculations for those examinations were going to be made based on our weight-based exposure chart that we have in our general X-ray rooms. And we also thought that while we were doing this project, it would be interesting to, at the same time, compare our three methods for long imaging, which we use for scoliosis or whole legs. And they are a Fuji CR stitching system, which we use for our one-shot wonders, children who cannot keep still long enough for stitching of any other sort, or children having traction applied. We also have a Shimatsu with Canon plate DR stitching that we use for our bending scoliosis pictures, supine bending scoliosis pictures, or our mega prosthesis, but there is a delay between the two image acquisitions or two or three image acquisitions in the stitching, which is why we hang on to the Fuji CR system. And we also have an EOS, which we use for the vast majority because of its dose saving. Once the examinations we wanted to include had been decided upon, Tori started the dose calculations. She used PCXMC Monte Carlo software, which is a software that physicists use for dose calculations. I don't pretend to understand how it works, but as we're all very visual being radiographers, I thought it's nice to have a peep inside what the interface of the software looks like. You'll notice that there's a place there to turn on and off the organs that are in the beam, as well as the different size phantoms. Of course, there were some challenges along the way. There always are. For us, the first one was that the Monte Carlo software has some limitations. The biggest one for us, the most obvious one for us, was that the phantom has no arms. So therefore, the dosimetry estimates for the upper limbs needed to be done using historically published data and adjusted for our exposure factors. And when it came to calculating the stochastic risk, as I said before, we needed an age and a weight. So we decided to use the 50th percentile of the World Health Organization's data for weight for age for girls and boys. You can see, and you may already know, that there is a weight for age chart for 0 to 10, and between 11 to 18 it's a BMI chart. The stochastic risk was taken as a lifetime attributable risk of a cancer incidence in addition to cancer mortality, and this was taken from the BS7 report. This is the most up-to-date and comprehensive risk estimates for cancer and other health effects from exposure to low-level ionizing radiation. It was published in 2006 by the National Research Council in America, and it's among the first of its reports to detail estimates for cancer incidence in addition to cancer mortality. It's based on a linear no-threshold risk model that indicates that the risk of a cancer proceeds in a linear fashion at low doses without a threshold, and that even the smallest dose has the potential to cause an increased risk to humans. So after many months of calculations, Tori's spreadsheets were getting absolutely enormous. For every projection, she had ages 0 to 18 and a 50th percentile weight for males and females. For each of those, I'd indicated the KVP and MAS that would be appropriate to use, and she had calculated the effective dose. That had been equated to a lifetime risk of cancer incidence from the BS7 report. She'd equated the Kalman risk category, calculated the equivalent BERT, and estimated the equivalent international flight times. What we had was a monumental piece of work. but not really something that we could pin up on the wall or use as easily to communicate the risk. We all sat down and looked at this information closely and thought a lot about how we could present it. The things that we noticed were that there was absolutely no difference in stochastic risk category between any of the projections, between males and females in any of the projections. So that reduced our information by half. We then also noticed that there were very big weight ranges for which that stochastic risk category didn't change. So we decided that that was how we condensed our information into the risk category from the BS7 report. So with the assistance of our in-house media department, these were the final production. These two posters, the one on radiographer's right, as you're looking at the screen, is the one for the general X-ray examinations, and the one on the radiographer's left, as you're looking at the screen, is for long stitching and EOS examinations. They're separate standalone posters. You'll notice that decision aids, such as the color coding, have been used. These visual presentations of risk information to information that are more familiar for people to relate to is very recommended in public health with risk communication. All the estimates that have been used here are in maximum values, and they have a little blurb included down one side so that the poster can mean something to somebody if they're just reading it standalone and not part of a discussion. They're on display in all of our general rooms. In the reporting room, they've been distributed to our orthopedic department and our emergency department, places that doctors may need to have discussions with parents around risk of radiation. They're very useful. I use them a lot. Let me give you an example. So today we've got, just imagine, a mother of a 5.5-year-old girl who happens to weigh about 19 kilos. She's here for her pelvis X-ray DDH follow-up. Mum's a little concerned because she's had a lot of X-rays about how much radiation she's going to get today. So we were able to take her to the poster and show her that her daughter sits in this category here of AP pelvis 3 to 25 kilos. She is not going to be the top of the range because, as I said, maximum values have been equated, and we're only talking about an exposure that's going to be relevant to a 19-kilo child. The typical effective dose is 0.02 millisieverts. It's considered to be a risk of a cancer induction of 1 in less than 182,000, which is minimal. Equivalent background radiation for us in Australia would be approximately 4.9 days or 8 hours of an international flight, at which mum is much more comfortable with the idea of less than 8 hours on an international flight. With every conversation, it's not always relevant to use the word cancer induction, but it is up there on display as it has been part of our research, so, for completeness, but not every conversation needs to use those words. And that has actually been some of the feedback that we've received regarding the posters, but we still think it should be there for completeness. It's a very useful tool to convey the associated risks of an X-ray examination in ways that are easy to understand. I personally have never felt as confident about discussing the risks and being able to explain the risks to parents as I am now, because the information that I'm using is relevant to the actual exposures that I'm using. So if you're interested in knowing more depth about this project, our work was published in the Journal of Medical Radiation Sciences earlier this year. This journal article addresses the work around the X-ray examinations, not the long imaging examinations. That may be a future publication. It definitely goes into more depth of how the calculations were done and outlines the limitations and the caveats of this work in more depth than I've had time to in this presentation. In the same journal, there was an editorial piece from Peter Thomas, the medical imaging director of ARPANSA, in which he said it's important for imaging facilities to be able to provide answers clearly and honestly, and to be able to provide a context so that benefits and risks of imaging can be understood to support informed decision making. It's also important to contextualize the estimated risk through comparison with other risks. And he actually quoted us as providing an example for an information sheet developed to assist staff at their facilities when discussing dose, risk, and benefits with patients and carers. So maybe this has inspired you to take on a similar project at your organization, or maybe you would like a copy of our posters. Remember, they are relevant to our exposures, but at least they're pediatric. You can contact me here if you have any further questions. Thank you.
Thank you, Amanda, for that amazing piece of work. I personally know how much work you has actually gone into putting something like that together, but it is an absolute great resource to have available in that. I will just remind people to, if you have any questions, just to put it into the chat, onto the Facebook Live page, and we will try to get to those questions at the conclusion of this webinar. Our next speaker is Christine Vanderlei Reichner. Christine was born in New Zealand in 1954 and graduated from DSR Southland Hospital in Kew, New Zealand in 1975. She is employed in a variety of roles as supervisor, application specialist, university lecturer in Australia and New Zealand and the Middle East since graduating, and has a special interest in CT scanning, contrast media, and radiation dose. She was awarded the Nicholas Outerside Medallion by Isrrt for her valuable contribution to the profession in 2013. And for those that are not from Australia, that is a very prestigious award to receive in Australia for the medical radiations profession. She has provided face-to-face and online contrast media and cannulation workshops for Isrrt and university undergraduates throughout Australia for more than 20 years. She's the co-author of the Ramscore Iodinated Contrast Media Guidelines from 2016 to current, which is the Australian and New Zealand College of Radiologists. And she's currently employed as a senior radiographer in Quality Education and Student Placement Coordinator at the Royal Hobart Hospital in Hobart, Tasmania, Australia, with a special interest in paediatric fluoroscopy and education. She currently enjoys living in Hobart, Australia, surrounded by good friends, a lively arts culture, and the stunning scenery of Tasmania. Christine is giving us a talk on the safe use of contrast media. Thank you, Christine.
Hello everyone, my name is Christine Vanderlei Reichner, and it is my privilege today to speak to you about radiographic contrast media and how we can make the administration of this product safer for everyone. I graduated in radiography in 1975, which I'm sure to some of you seems a very long time ago. I'm currently employed as a senior radiographer of quality and education at the Royal Hobart Hospital in Tasmania, Australia. But I've spent almost all my entire life talking about contrast media to radiographic students, to universities, and to anyone else who would listen. I've also been lucky enough to have been the co-author of the Royal Australian New Zealand College of Radiologists Iodinated Contrast Media, one of the national guideline structures for Australia. How can we improve patient safety and outcomes during and after contrast administration? Well, I believe it's all about our knowledge and our skill, the information that we have, and how we share and display that knowledge to our patients, to our team, and to our referrers. It's also about how we deal with incidents as they happen and how we recognise them. And most of all, it's probably about our facilities and our training, because it's with good training and good understanding of what is going on that we can prevent an incident escalating. What is radiographic contrast media? Well, there's basically three types. There's barium-based, gadolinium-based, and iodine-based. And these are all metals that either absorb the radiation or change the way the bodies react to the product as an MR, where the tissue relaxation time is changed. They are, of course, a chemical compound based on chemical structures with bonds. And these bonds are then held together and mixed with various other stabilizers and buffers, and we call these moieties. And it's the moieties, in fact, in the contrast media that most of the patients have an allergic response to or an adverse incident. One of the most common things we see in day-to-day practice is what we would call the osmolarity-based. And it's not really an adverse incident, it's something that happens with most of the patients. And this is where they get that heat or flushing sensation, especially around their face and neck. And this usually settles quite quickly. Some patients may feel that they need to vomit. The vasovagal, where in fact their blood pressure lowers. This can be followed by cardiovascular collapse, but that is very rare. The thromboembolic event, also very rare, but most commonly it is a change in blood pressure, either a lowering or an increase. And these symptoms usually subside really quite quickly. Allergic responses, however, are much more rare, and they're a hypersensitivity reaction, and they may also cause vomiting, and often they cause a rash, but they can also cause collapse and facial edema and laryngeal edema. And it's these things that we need to be able to treat or recognise very quickly. Another adverse incident that patients can be affected by, and I'll call this the chemical reaction or chemistry. And one of these is probably the most common, are things like drug-to-drug or drug-to-medication reactions. For example, something like metformin, which they may be on for their diabetes. Acute kidney damage for patients who've got poor renal function. Patients who've got high thyroid levels, and this can cause a thyroid storm, which can play havoc with patients' blood pressure. And another one, sickle cell anemia crisis, which I have actually never witnessed, but is well documented. Other patients' comorbidities, however, much more common. Patients who are diabetic, whether they're type 1 or 2, and this is a disease that also causes vascular changes in the patients, and vascular changes, of course, can lead to changes in their renal function. And these patients can have a reduced renal function, and these need to be checked before we give them iodinated contrast or gadolinium. Renal disease, however, I've listed separately because these patients may have had renal damage from a previous stone or infection, or patients, in fact, who've had renal transplants. Patients who have hypothyroidism or overactive thyroids, we need to be very careful about giving them iodinated contrast media because this can follow by an adverse incident. There are other medications that patients may be on that we're not aware of, and that's why a really good patient safety questionnaire is vital before the administration of any other medication. Patients who have adrenal disease, such things as a pheochromocytoma, a peculiar tumour that affects the patient's blood pressure. These things need to be checked before we give them any other medications. There are three main myths and or misinformation that I currently and commonly see out there in the workplace. Number one, you cannot be allergic to radiographic contrast media if you've not had it before. If you're allergic to seafood or betadine, you're probably allergic to X-ray dye and you shouldn't have it. Or if you've had contrast media before, you're unlucky to suffer an allergic reaction. We know all of these to be untrue. All allergic responses, besides being rare, are really unpredictable. And because these products contain iodine or gadolinium, and it's not those metals that you're allergic to, it's the buffers and stabilizers, or any of them, or all of which patients can actually be allergic to. But we do know there are groups of patients who are at increased risk. So 1 in 6,000 radiographic contrast media administrations will experience some sort of allergic response. 1 in 10,000, however, that these could be called aggressive, and these usually involve the patients being kept back or the patients requiring some other medications to reduce the effects of the allergic response. But we know that almost all life-threatening contrast reactions occur within those first 20 minutes, and they may be referred to as the golden time. And these are the moments that patients should be kept in the department before they're discharged. There are some other patients who are at increased risk, and there are some good articles out there, and this comes from Radiopedia, where 200 times increased risk if patients had a previous reaction to iodinated contrast media. So this is actually quite substantial. Hypothyroidism, so 5 times a risk if you've got a family history. They're 14 times more likely to have an allergic response, including asthma. Previous history of multiple allergies is not a contraindication, but a more detailed history of the patient should be obtained. We also are aware that patients who have high anxiety levels are much more elevated risk of a non-vagal contrast media reaction. In other words, a reaction where we alter their blood pressure. However, the route does not matter, and I've had questions from surgeons in the operating theatre saying, this person is allergic to iodinated contrast. Can I inject contrast into their renal bladder or into their ureters? And in fact, small amounts, of course, will pass into the bloodstream, and the patient could have a reaction after that. Now, armed with some of that knowledge, what can we do to change how we look after patients? Well, the first thing I think we need to do is change how we talk to patients or how we question them. So we need to replace the question like, are you allergic to contrast media or X-ray dye? Or have you had this injection before? To something like, are you allergic to any drugs or medications? Do you have any other food sensitivity? Do you have asthma? Do you have hay fever? And what happened the last time you had it, if they've had it before? And this can give you a chance to talk about things like the osmolar response and reassure them that those things are absolutely, completely normal, and that they may or may not experience them with subsequent injections. But the risk of having a severe allergic response to contrast is actually very small, between 0.04 and 0.004% of patients who are receiving a non-ionic or low osmolality iodinated contrast. And these are well documented in this really good article about adverse reactions in Radiopedia. So the osmolar effect for contrast. So the severity of the osmolar effect, and they're usually dependent on the volume or the rate that we give contrast. Now, if you have a normal IV on the ward or in the emergency department, they will give it most medications at less than 1 ml per second, and certainly less than 1 ml per gram in weight. How can we identify an allergic or adverse incident? Well, the most common thing we can see in patients is probably some vomiting or some nausea. And if we get the patient to take some nice slow breaths, that usually settles quite quickly. Hives or a rash or sneezing, itchy eyes or watery eyes may be followed. Shortness of breath or wheezing is not uncommon. A skin reddening, some pain that the patient experiences. That may be accompanied by a cough or hoarse voice. Some patients describe stomach cramps. Some patients get the swelling of the face or the lips, and I put a little picture here to remind you of what it can look like. So looking at your patients as you put them on the table is really important. Some patients may become vague, and this may be caused by a change in their blood pressure. And some of those can in fact lead to fainting or collapse and a loss of consciousness. So all of these are those serious allergic adverse incidents that means that we need to call for help really quickly. But as I said before, true contrast media allergic reactions are very rare, and we need to share this with the patients. So a true allergic response is triggered by the protein or the immunoglobulin E, IgE, and for any allergen that the patient may have. And these molecules then bind with the allergen molecules in an antigen or antibody reaction, and then this triggers the release of histamines. And that's why we give antihistamines when patients are having allergic responses. And these chemicals cause the inflammatory symptoms in the allergic response, the hives, the rash, the sneezing, and the itching. An anaphylactic or allergic shock typically happen within 24 hours, but metal, the iodine or gadolinium are extremely rarely the cause of an allergic response. As I've said earlier, it's typically the moieties that these actual medications are mixed with. So what are in these moieties? Well, these are the buffers and the stabilizers, and there's a whole list of them. And some of them could be a product called trimethamine, all right, which or etatate, calcium dioxide, sodium hydroxide, sodium chloride acid. And it's actually quite hard to actually find out what are the medications or what are the drugs and things that are actually mixed with the contrast media that you are actually giving to patients that they may in fact be sensitive to. And most of these products patients have never had before. So that's why I've said that a really good patient history and communication and a good medical history in that questionnaire, things like asking them what kind of medications they're on and more specifically, what are they taking them for? Previous and other diseases, especially thyroid disease, renal function disease. Are the patients on beta blockers or blood thinners, because that means you need to leave those cannulas in slightly longer, or bronchodilators, because all of these medications give a clue to you as a medical radiation practitioner about the patient's medical history. You need to ask them about their family history or allergies within their family. And of course, the most important question before you proceed with anything is asking the patient, do they have any questions? Because a patient who is relaxed, as I've said before, and less anxious patients have fewer responses or things to the contrast media. Post and during the injection, you need to monitor patients really carefully, being particularly alert for things like sneezing, redness, swallowing, difficulty in breathing, and vagueness, and hives and swelling. And you should wait at least 10 minutes before you remove the IV cannula. And that's not because the medications that you need to give them if the patient is having an allergic response are given intravenously. They're not. Adrenaline or epinephrine is always given intramuscularly, but some of the other medications that you may need to give the patients, like fluids, need to be given intravenously. And of course, before you take that cannula out, it's really important that you ask, are you okay? And ensure, of course, that you document everything and retain this as part of the patient record. Patient monitoring, and I'm not talking about equipment, but changes in the patient's appearance or breathing or alertness, and this needs to be combined with other sufficient resources. For example, some training in who and how to call for help. I have a big red buzzer, which makes things much easier. So who does what in the team? What is in the drug box, and the importance of everyone knowing the medications, the dose, the route. In an allergic response, as I've said, it's the IM, adrenaline or epinephrine has to be the first line of attack. Of course, these things need to be documented. That, of course, also involves the fact that in your departments, you should have a daily routine where all equipment gets checked and cleaned and reassembled. You needed to have practiced your resuscitation skills. You need to have yearly resuscitation, BLS or CPR training. You need to practice drills of who does what and when. And you need good equipment like buzzers and safety equipment and monitoring and stethoscopes, scoops to help get patients off floors, oxygen masks that fit the patient, especially if you're doing children. You need a variety of suction tubes and catheters and airways. I'd like to thank you all for attending, and I'd like to thank the ISRR team for the opportunity to talk to you all. Have a good day.
Thank you, Christine, for that wonderful talk. I really love how you just put it all together as far as contrast is concerned. It's a very, very big kind of topic in that, and I think you really nailed it there as far as putting it all together. So thank you very much. Our final speaker for today's webinar is Dr. Andrew England, and Dr. England is a senior lecturer in medical imaging and radiation therapy working at the University College in Cork in Ireland. His work focuses upon diagnostic radiography and radiation therapy education and research into the areas of radiographic practice, dose, optimization, digital imaging technologies, including CT, MRI, and mammography. His publications explore patient-centered care as well as novel technologies and techniques that enhance the detection of clinical indicators of disease whilst minimising the risk to the patient. His research has been disseminated through major international imaging meetings, including the annual meetings of the European Congress of Radiology, Radiological Society of North America, Arab Health, and the UK Imaging and Oncology Conference. He is the recipient of several prestigious research awards. In total, he has published over 100 original papers in the highest-ranked radiological journals. He has generated more than 400,000 euros of funding. He is a fellow of the Higher Education Academy and has sat on the European Congress of Radiology Program Planning Committee. He is currently president of the European Federation of Radiography Societies, or the EFRS. Andrew is going to be giving us a talk on the effective dose optimization in an era of digital radiography. Are we meeting the ALARA principle? Thank you, Andrew, for your contribution.
Hello and welcome. My name is Andrew England. I'm a senior lecturer in medical imaging and radiation therapy at University College Cork in Ireland. I'm also the president of the European Federation of Radiographer Societies. I first of all would like to thank the Isrrt for the kind opportunity to deliver this presentation on World Radiography Day. I'm going to talk about effective dose optimization in an era of digital radiography and the question, are we meeting the ALARA principle? So a little bit about me first. I'm a qualified diagnostic radiographer. I have been for over 20 years. I currently work as an academic teaching and researching in radiography at University College Cork in Ireland. So it's on the southwest coast of Ireland, and I still live in the United Kingdom, so about 300 miles away from where I work. I have over 100 publications relating to research in diagnostic radiography, and I've given probably now over 150 presentations at national and international conferences. And as I've said, a year ago I was elected as the president of the European Federation of Radiographer Societies. So just to set the scene and perhaps make sure we're all understanding some of the terms, we're going to look at optimization, ALARA, and digital radiography. If we just take digital radiography first. So we're perhaps all aware that there are a number of types of digital radiography out there, and there's a lot of similarities. So all digital systems will have an X-ray tube, and there'll be a variety of things in the room. There may be an imaging table, there may be an erect bookie. The bit where there's a difference is really in terms of collecting the X-ray photons that have exited the patient. And there are really two categories of digital technology out there. There are indirect detectors and there are direct detectors. And all we need to perhaps consider in between the two is in the indirect detectors, the X-ray photons hit the detector and are converted into visible light. There is a scintillator. So a scintillator is essentially a material that when it's bombarded with X-ray photons produces light, and there is then some electronics attached closely, either a charge coupled device or a thin film transistor with a photodiode very, very close, and essentially turn that visible light into an electrical signal that then goes on to produce the image that we see. The direct option over on the right of the image is we have the X-ray tube. It produces radiation, it's attenuated by the patient, and it goes to a detector where the X-ray photons that bombard the detector are converted into a direct electrical signal. So there is no light production as we would see with the indirect approaches. So what we need to think from this slide really is that digital technologies are about producing an electrical signal that a computer will ultimately convert to the visible X-ray image, the radiograph that we commonly see. And this is very, very different in the approach compared to what happened for 80 and 90 years of radiography where we used the X-ray film. So let's have a little look now at X-ray film in comparison with digital radiography. So if we look over on the left of the image, we've got our X-ray film, and there was a very, very well established relationship. As we increased the dose of radiation, we went from an image that was overly white to one that we would have said was optimally exposed to one that was too dark. It was overexposed. So there was a very, very clear relationship in terms of the visualization, particularly the density on the image, and radiation dose. So it was very easy to know whether an image was under, over, or correctly exposed. With digital systems have a much wider latitude, and again, it's one of the reasons why they've been so successful over the last 20 years. So with digital systems, as you increase the radiation dose, the system compensates for that and keeps the image quality the same, and that's why we can see these three digital images almost look identical, even though they were acquired with different radiation dose levels. So therefore, if we ask the question of the film, which one is the optimal image, which is the one that's suitable for diagnosis, we would take the middle one. For digital, we could take any of the three, and they would have been produced with different radiation doses. So in essence, we don't know from the digital whether we have got the exposure as low as acceptable, and therefore digital radiography gives us challenges in knowing whether we've used the lowest possible radiation dose. So this brings me on to my next part of the talk, is dose optimization and the Isrrt principle. All radiographers amongst us will be well aware of the Isrrt principle, as low as reasonably achievable. And in essence, it's saying we should use the lowest amount of radiation really to answer the clinical question. And this is really this concept of dose optimization. So Isrrt is kind of the aim. Dose optimization is how we do it. So we try and get the doses low, but really answering that clinical question. And how do we get the dose low? We adjust different acquisition parameters. So that might be things like the tube current, it might be things like the tube potential, it might be using additional filtration, removal, or inclusion of a grid, and so on. So therefore, we have to ask ourselves for every patient, have we achieved as low as reasonably achievable? Have we achieved the Isrrt principle? And if so, how do we know that? How can we evidence that we have that at the lowest? So, as I've said from the beginning, the dose response, so how the image changes in result to different radiation dose levels, is very different than what we would have seen for film screen. So in film, we would have typically seen increase in image quality up to a point, and then as we continue to increase the exposure, the image quality would have dropped off. So starting from something that was too light and ending up in something that was too dark. For digital systems, we see an improvement of image quality up to a point where we see no further benefit. We have a plateau. Some might argue at very high radiation dose levels, we may see a slight deterioration, but generally we see an increase, and then we have a point which we get the threshold where we see no further improvement or a change in image quality as a result of dose. And at that point, this area where we get the plateau, we could be increasing the radiation dose and see no visible change in image quality. And therefore, we are almost overexposing the patient with no benefit. We are not optimized and we're not achieving Isrrt. What we also have to consider is that there is no single image quality kind of standard per examination. We have to think about it as indication-based image quality. So if, for instance, I was asking you to perform a hip x-ray on a patient, you could, or you perhaps would, accept different levels of image quality depending on the clinical question. So in this example, if you were asked to search for an occult fracture, you maybe need the highest level of image quality. If you were asked to confirm whether there was a joint dislocation, then maybe you could accept a much lower level of image quality. Some things are much easier to see. So if we can vary the required image quality on an indication level, so a per patient basis, then our exposure factors, our setup of the patient will also need to vary on a patient by patient basis. Now, ask yourself really in your systems, if you were to choose an AP examination of the hip, do you really think about it in that way? Would there be 3 or 4 different settings that you would use depending on the clinical indication? So if we just consider now, imagine we're just going to agree that the next patient we're going to examine, we're looking for an occult fracture of the hip. So we need perhaps the very highest available image quality. Now, I would ask you to consider whether there may be several techniques out there which would produce that level of image quality, but with the differences in radiation dose. So could we achieve the same image quality by using different tube potentials, but then adjusting the MA to compensate? Could we achieve the same image quality maybe with using things like an extended SID or using additional filtration? So is it possible, I guess if we were cooking, is there maybe 3 or 4 ways of making a chocolate cake that could potentially taste the same? And if we're promoting dose optimization, so the Isrrt principle, we need to be confident that when we're aiming for an image quality, we're using the technique with the lowest radiation dose. Now, I don't believe we're necessarily at this point in time. I believe that we can make decisions about whether we've got acceptable image quality, but we perhaps need to maybe spend more attention about understanding whether we've got the lowest possible radiation dose. So some might say, yeah, but we do this already. Whenever I examine a patient, we've spent lots of time in terms of quality assurance and devising protocols. But I just want to share this graphic from a study that was undertaken in Manchester in the UK. This was from a former PhD student. And he went around to various hospitals. Some hospitals would have had several X-ray rooms, and almost presented them with a phantom, the same phantom, and said, can you x-ray this as it simulating a chest x-ray with your standard adult protocol? And what we can see from this graphic quite quickly is both the radiation dose, so that's the sort of the line that's moving across the image, and the image quality, which is the bars, did vary considerably between room and between hospitals. So if we're thinking we've got optimization, you think that really for the standard patient, standard chest x-ray, we would be producing the same image quality and with approximately the same dose in every instance. Clear evidence that this isn't happening in every case. What we know is that it is possible to achieve a desired level of image quality, but that there can be many techniques we can use this. Radiography has a unique opportunity in that there are many different parameters that we can select, which ultimately influence both image quality and dose. But imagine many combinations of these produce the same level of image quality, but with a variety of doses. Are we confident that we're selecting for our patients the composition of parameters which deliver the lowest radiation dose? Thus is Isrrt. What we do know, there's been a lot of work out there. There have been studies reported in the literature using phantoms, humans, looking at trying to identify what are the correct exposure factors, the correct acquisition parameters to deliver the lowest dose with an acceptable level of image quality. This is only a small list, it's not the whole list. There'll be many, many other examples out there. So in summary, this was a very good opportunity to get to speak to you today and talk to you about optimization and Isrrt in a digital era. Dose optimization, getting this dose as low as possible whilst maintaining image quality in many jurisdictions around the world is a legal requirement. With digital systems, we know overexposure is a challenge. It's not necessarily visual on an image. We know from studies, we know from our own experience that some information is conveyed by numerical indicators such as exposure indices, but again, how they correlate with radiation dose, and how they vary between manufacturers and body parts, again, is poorly understood. So as I've said, exposure indices can be difficult to interpret. And we've also got to think about wider problems such as indication and patient-specific optimization. So that idea of picking up an adult chest x-ray and assuming those parameters fit every adult that can walk into our x-ray rooms and be examined at the erect bucky isn't going to be fit. Could we use a lower dose if we were looking for things like a large pleural effusion? Would we maybe need a higher dose if we were looking for a subtle pulmonary nodule? Just the same as if we were looking to confirm the presence of maybe a nasogastric tube, or to confirm that a hip joint is back in position after it being relocated following a fall. So being confident that we have the best exposure factors and best acquisition practices to produce ALARA globally is one question, but are we doing it on a patient by patient basis? And this brings us to this idea of avoiding dose creep. One size does not fit all. If we look at this slide in terms of the human population, we are massively variable in terms of our size, but also when we think about radiographic practice in the reasons for imaging. So when we're thinking about ALARA, my final conclusion based there is we've taken great leaps in terms of how we practice radiography in a digital area. We are optimizing more and more examinations, but I suppose my feeling, my message to you is we're perhaps not doing it as much as we can on a patient by patient basis. So personalized radiography, we're not there yet. So thank you for listening. Have a happy World Radiography Day. And again, thank you to the Isrrt for the opportunity to speak. Thank you.
Thank you, Andrew. That was a very, very good talk on trying to really think about ways that we can optimize the radiation dose. I'd like to invite our three speakers to turn on their cameras as we do have a couple of questions. Hello all, thank you for joining, and happy World Radiography Day to you all. Amanda, I'd just like to start with you. That was excellent work on putting together a very, very comprehensive resource for us to all use, of course. Given the relatively quick turnaround time that a patient needs to be in the X-ray room, and you know, we obviously have pressures of making sure that we keep our workflow moving, with such a comprehensive resource that we have, you did touch on this a little bit during the presentation, but what would you recommend that we focus on when we're having that discussion with a patient or a parent about their radiation dose?
To be honest, we usually have that discussion around gaining verbal consent to image. So I tend to focus on the word, the minimal or negligible word, and I do comment on the background radiation time. You can see pretty quickly if somebody's comprehending that or not, or equate it to the international flying times. And I'm noticing that the vast majority of parents feel more comfortable comprehending the international flight times. It's like, oh, like a flight to Singapore, that's fine. We can do the X-ray. Yeah.
Yeah, something that I think that they're much more likely to kind of understand and assimilate to, I guess, in that sense as well.
Absolutely. But we have had a few parents who obviously academics or mathematicians who were appreciative of the other numbers being there too.
Yeah, that's good to know. Yeah, thank you. Christine, you asked the patient whether they have an allergic reaction to foods. Like that was one of your recommendations, is to kind of thinking about, you don't have any food allergies or anything like that. Now, let's say that the patient then just says yes, that they do. What would be the next step that you would actually follow, that you recommend?
I think then you need to look at the range of foods, if it's all in one food group, so it's something in that actual food itself. Are there other family members that have got lots of allergies as well? And the severity of it. Have you ever had a hospital admission? Have you required drugs to reverse the how bad were the hives, how bad was the swelling. And we do know that the more allergies that a patient has, the more likely they are to be allergic to something else, whether it's another food stuff. We know that people say, oh, I'm allergic to gluten, but that is an intolerance, not an allergy. So you need to just have a conversation and try and draw them out and get some more information that you can discuss with your radiologist. But we do know that the more atopic or the more allergies that a patient has, the more likely they are to be allergic to something else. But also you don't want to make them more anxious, because we know that anxiety has its other side effects. And it's that sort of balancing act, a bit like Andrew's talking about radiation dose and trying to get the right image. It's also in communication, like Amanda talked about. You don't want to make them anxious, but you need to know enough information so that we can work as a team and do it safely.
Yeah, absolutely. And when it comes to the role of radiographers in kind of understanding the effects of contrast and I guess responding to a deteriorating patient as a result of some sort of allergic reaction, what has Australia done? For those that are not from Australia, what has Australia done in this kind of regard to work on this kind of project?
I think that, and I don't know what, having predominantly worked in Australia recently, at the moment in Australia, even though we are not legally allowed to inject anything else other than radiographic contrast media and saline as flushing agents, we are not licensed, except if we're on a main street, for example, but in our workplaces, we're not allowed to give epinephrine. And we're not allowed to give buscopan or GTN or any of those other drugs for most of our drug state-by-state regulations. But if you're on the street and somebody has an allergic response and they carry adrenaline or epinephrine pen, you can actually use the EpiPen, and it's not hard to use. Australia, the Isrrt, our national body, are actually working on a project to allow radiographers to actually inject epinephrine, because we know that it's epinephrine that supports the vascular system for the patient and their airways and things to reverse that swelling. It's that they need fast. Things like adrenaline have the best effect. Even an antihistamine or steroids, they take 10 to 15 minutes to work, but it's that epinephrine that they need immediately. And I myself have worked in practices where the radiologist will say, oh, look, I'll be in the T room if you need me. But the T room is, 2 blocks away almost at the other end of the hospital. And you don't have a big red buzzer to call for the emergency response team where the whole department turns up. I think it's really important that we are allowed to give much more supportive medication. In some places, we're not even allowed to actually apply an oxygen mask.
Yeah, I think it is really, really important, particularly for what we, in terms of my workplace, in terms of what we refer to as the first 3 minutes, which is the first 3 minutes before you're actually waiting for help to arrive in terms of what we can actually do. So I think it's good to hear that there are some forward steps in that kind of process as well. Andrew, is just as a side question, is there anything in your part of the world that may be a little bit more advanced on that side of things than Australia are in terms of the contrast reactions?
I guess it's very pocketed. I wouldn't say that it was, there was certainly in some countries there can be, I guess protocols put in place where, I guess advanced drug delivery can happen, such as things like buscopan. I'm not sure in terms of a contrast reaction whether that would extend, because again, it's got to be very prescriptive. So, if it was a CT examination where you needed buscopan, that could be very, the criteria could be very clear. I guess we've all had contrast reactions, they vary in range, and I guess that decision at what point do you give intramuscular epinephrine, I guess that's a decision. But I think that's something where we do need to go as a profession. If I take maybe European and probably global experience, that with teleradiology, there are less radiologists available in the department. Many might work from satellite clinics, maybe even from home. And of course, you've got the correct contrast cover, but that could be spread between many modalities. So, in the past, the radiologist might have been just across the corridor or, maybe in an adjacent room to the CT scanner. That's not always the case. And in some hospitals and clinics, it might not even be radiology trained medical staff that are providing contrast cover. So I do think there is a greater role for the radiographer there in potentially more of a lead role. Obviously, it's got to be safe for the patient. It's got to be safe for the professional as well. We shouldn't be in a position where we're doing something that's not within our scope of practice. But I do think we are the patient. We are at the patient interface. We are the first kind of identifier of that reaction, and therefore we should, from that point in time, have a clear strategy on how that's going to be managed. Of course, with medical help, with colleagues. But again, I think if we're thinking about patient care, which again, this World Radiography Day and patient safety, if we really want to give the patients the best experience, we have to form a greater part of that kind of management of contrast reactions.
Yeah, absolutely. Thank you, Andrew. Andrew, I would like to thank you for joining us online. I know it's a lot earlier in the day for you than it is for both Christine and for Amanda. To put it into context, it's 11:05 p.m. here in Australia at the moment. So, Andrew, just one question. One of the things that you actually mentioned right at the end of your presentation was that we're not quite there yet. Will we ever get there?
I guess I always think radiographers are we're very ambitious in terms of we want perfection for ourselves as professionals, but for our patients, and quite rightly so. So I don't think you'll maybe ever have a radiographer say, yes, we are fully there. I think there's always more we can do in terms of patient safety and dose reduction. I think the point that I'm making, want to make from that really is that we've seen a great deal in terms of the technology that's available to us now. And I think that's going to help us personalize radiation doses and optimize better. So we have, as a profession, we've got to embrace those technologies. But at the same time, we've also got to accept some cultural changes. I think radiography, really has come out, if you think of the 100 plus years of radiography, a lot of it really has been kind of tradition. Our evidence base is growing, with leaps and bounds, but, it's relatively small, maybe compared to some other professions. So I think we do need to maybe at times look and say, really, are we embracing the technologies? Are we giving the time, and that's so difficult, with busy departments, to really consider, what's the examination? Is there a way I could lower the dose but still achieve the same image quality? We're tasked with being super efficient in terms of busy waiting rooms, extensive waiting lists, in and outside the hospital. So being quick, being safe, but also, producing, the optimum images. So, the radiographer role, that's why I guess we love it. That's why we're here, is so vast. And, we're juggling so many things, but I guess, hopefully the technology, hopefully evidence, hopefully, improvements in how we see ourselves as a profession will help us get close to that line where maybe we say we're touching it. We're not fully there, but we're a lot closer than we were.
Yeah, that's good to hear. And I think that as well, like one of the other points that I was kind of thinking about while I was watching your presentation was about answering the clinical question, because I think a lot of people are very quick to, as you say, we all strive for perfection. And I think a lot of people are very quick to repeat x-rays based on the fact that an x-ray may not necessarily be perfect. But if we've answered the clinical question, then that should also be sufficient anyway. I also wonder as well, based on what your talk was about, you talked a lot about the ALARA principle, and that's obviously something that is ingrained in every radiographer's kind of brain in that. I wonder whether we need to almost change it to something that's probably not as catchy as ALARA, and that is ALAOA, which is as low as optimally achievable.
Yeah, I think so. When I was doing a little bit of preparation for this talk, there's a variety of, I guess, schools of thought out there. And some would say because the doses are coming down so low, almost is the fact that doses are so low, really, do we need, for sort of digital radiography? I would always contest that we do. There are potential stochastic risks with any dose of radiation. So therefore, but, I can see where some of those arguments, how much time do you spend on optimizing, say, an X-ray of somebody's finger versus, a CT perfusion scan. And I get that. So, but I think that you're absolutely right to think about whether the terms that we use are now the most appropriate. and really fitting in, I guess, with what we know about radiation safety and what we know about the modalities that we use. But I guess as a profession and what our patient wants, and it was interesting to hear the contrast media talk again about we've got to be responsive to our patients in terms of what do they want to know about contrast safety. We've got to be honest. With our patients, absolutely, but at the same, we don't want to put that that much fear in our discussions that patients say I don't want that contrast, and therefore there's actually a negative detriment as a result. So I think we've got to change the landscape. Patient expectations are becoming different, doses are changing, so some of these terms, some of the ways we practice will need to evolve.
Yeah, absolutely. I think you've hit the nail right on the head there. And it'll be also interesting to see, I think, as we move more into the digital age, I think, as well as to how that perception from radiographers also changes as well. Andrew, Christine, and Amanda, thank you all very much for joining us. Thank you very much for your wonderful presentations. They've all been extremely insightful, and I really hope that the audience has certainly got a lot out of it. Happy World Radiography Day to the three of you. Christine and Amanda, you may now go to bed and go to sleep. Thank you. Andrew,
Thank you.
Thank you.
Back to work. I'm only halfway through. So yeah, and just to say thank you to the Isrrt for the opportunity. Happy World Radiography Today to those online, and it was great to see my fellow presenters online. It's great that we can do this. As you say, you're in Australia. It's almost bedtime. It's absolutely fantastic that we can join as a global radiography community. So thank you.
And thank you again for the officers.
Good night, everyone.
No problem. Thank you.
Good night.
And thank you, everyone.
Thanks, Stephen.
Thank you. Bye for now.
Bye-bye.